Hi, I'm Dr. Derek Mitleider. Today we're going to be talking about knee embolization, something that you might see referred to as GAE. This is a procedure that you may have heard little or nothing about, but it's something that's going to become more common as more patients with knee pain and osteoarthritis and limited mobility find out about this minimally invasive therapy that has a profound impact on those who undergo the procedure. So, what is knee embolization? Knee embolization is a minimally invasive procedure that treats inflammation and pain in the knee joint. It's also known as genicular artery embolization. Genicular arteries are the arteries that supply the knee joint, and it's sometimes abbreviated as GAE. Knee osteoarthritis is the disease state that we're talking about here. Originally, it was thought to be due entirely from wear and tear of the joint, and this applies to any joint in the human body. The knee, the shoulder, the ankle, that the more you used it, the more likely you were to develop degenerative change of it. And what we found over time is that chronic inflammation is actually playing a huge role in the development of joint destruction and degeneration over time. Chronic inflammation is inflammation that is directly related to excess circulation to an area of the body. That you develop inflammation because of use or because of injury, and this inflammation in and of itself recruits more circulation to the area, which in and of itself promotes more inflammation. And you end up with this vicious cycle that feeds on itself, and reducing blood flow, reducing circulation to the area of inflammation can interrupt this cycle and can lead to symptom improvement in a majority of patients. Knee osteoarthritis is a condition that affects at least a third of individuals older than 50 years old, and worldwide, it is a leading cause of disability of individuals. There are multiple risk factors. The first and foremost is age itself. Weight plays a role, genetics, gender, repetitive stress injuries, and previous knee injury. You injure your knee, and that causes an inflammatory reaction that causes an increase in circulation, which starts this process of degeneration and destruction over a relatively long period of time in most patients. Here we have schematics of a normal and non-normal knee, and you can see that there are multiple components, including the bone, cartilage, ligaments, tendons, and you also have these linings. On the left, it's green. On the right, it's red. The lining is the synovium, and the synovium can become thickened and inflamed in an inflamed, degenerated knee joint, and that is one of the things that we're targeting with genicular artery embolization. We grade the degree of degeneration using what's called the Kellgren-Lawrence osteoarthritis classification criteria, which basically means you take x-rays of a patient's knee and they fall into one of four categories or one of four grades. The important thing to note here is that the mild, moderate, severe refers to changes on the x-ray. It does not refer to the severity of the patient's pain. You can have severe pain with only mild changes on x-ray, and those two are not necessarily directly linked. This is the Womack scale. This is a measure that we give to every patient who comes to our clinic to talk about knee embolization. And the important thing to note here is that it's a lot of questions, 24 of them, but only 5 of them actually are directly attributable to pain. The majority of them, 17 of them, are attributable to function, because that is what we're trying to improve with the procedure. We're looking for a holistic effect. We're not just looking to temporarily improve your pain like taking an Advil or an ibuprofen. We're looking to improve your pain long term and also improve your function so that this has a durable, long term positive effect on your ability to carry out your activities of daily living, which is what the 17 questions are about. So, what treatment options are out there? For relatively mild symptoms, lifestyle modification. Are there things that you can do differently so you don't exacerbate the degenerative changes that you have in your knee and reduce the pain associated with it? You can also take temporary measures like NSAIDs, like ibuprofen, like Motrin, in order to temporarily address the inflammation in your knee joint and to temporarily improve your pain. For moderate symptoms, there are joint injections that are relatively common, which includes a steroid for most joint injections, again, to address the inflammatory component. And also nerve ablations are done in some patients to improve pain. For the most severe osteoarthritis, the most severe pain and degeneration, Patients, if they're surgical candidates and if they're willing to go through a major surgical procedure, are often offered to have a joint replacement. And with a joint replacement, it is major surgery. It requires a major commitment of physical therapy multiple days a week over a long period of time. And it also has a prolonged recovery before you can even resume what were activities of daily living prior to the surgical procedure. So, where does knee embolization fit in as a treatment option? And again, embolization is specific to address the inflammation that is contributing to the pain and disability that an individual has with joint destruction. Embolization reduces the circulation to the inflammation. That is how it works. And by reducing the circulation to the area of inflammation, it interrupts the cycle of inflammation, pain, and joint destruction. It does not remove the effects of previous joint destruction, but it stops the cycle of joint destruction and helps patients improve pain and function. So globally, like, what is embolization? This is something that we do all over in the human body, in my field, and it is something that involves putting a material into a blood vessel in order to decrease the circulation. This material could be small plastic beads, like you see on the right and on the left here. The green ones on the right, those are a little bit smaller than a millimeter in size. The ones on the left are even smaller than that. And you inject these through a tiny little tube. That yellow tube is magnified, and I'll show you a more appropriate image later that shows you truly how microscopic this tube is. And the beads come out one after the other, basically squished down in the tube because it is so small. And we use different types of particles, different types of embolics, depending on what type of a disease process we're trying to treat, what part of the body. And the most common thing that is used worldwide for genicular artery embolization, for knee embolization, is a mixture of two medications, imipenem and cilastatin. When you mix these two together and then you add contrast or dye to the mixture, it causes particles to form. And these are very small particles, and they are temporary particles that typically only last a couple of days. And these are what are used most commonly worldwide for knee embolization, shoulder embolization, and there's a lot of ongoing research into other areas such as hand embolization for patients with debilitating hand osteoarthritis. And there's a picture of the particles that are used in the procedure. And again, they are temporary and will dissolve. This is a video that shows the procedure itself, or an animation of the procedure itself. That's that tiny little tube, a microcatheter that goes into a branch of your artery that feeds the knee joint, in this case, a genicular artery, an inferior medial genicular artery. And we're injecting the microscopic particles in that are filling preferentially those branches that have grown in response to the inflammation, the vessels that are too big, too numerous, and causing joint destruction and inflammation. And when you inject these particles eventually will preferentially fill these branches that should not be there in the size and number that are there. And these particles will eventually cause these vessels to fill and will cause them to atrophy over time, which is what you're seeing a representation of here. And when they atrophy, that's when patients get the symptomatic relief. So, a few questions on knee embolization. Is it FDA approved? I get asked this every time. Yes, it is FDA approved, and it has been FDA approved for some time. Is it covered by Medicare? In almost all cases, yes. Usually, yes is the fair answer. Is it covered by private insurance? Again, usually yes, but it does depend on the plan. And can a patient self-refer for knee embolization? The answer is absolutely yes, you can. And in fact, a lot of patients in our practice, most patients self-refer because it's a procedure, it's a treatment type that they aren't told about as an option for their osteoarthritis. And so that's how they end up finding their way to us so that we can evaluate them and talk to them about whether this is something that would serve them well. And in this image off to the right, you can see where the yellow arrow is. That's actually showing you the tip of one of the microcatheters in a patient that we were treating. It shows you how truly small that tube is that's injecting these particles into those abnormal branches feeding the arthritic changes in the knee. So what's the recovery after the procedure itself? We discharge our patients post procedure within 1 hour. You do not spend the night in our center. You do not spend the night anywhere except your own bed in your own home. And when you leave, you are able to walk. You have minimal limitations. Nothing heavier than a gallon of milk is what we say, and that's about 8 pounds. And we ask you to do that for about 3 days. Otherwise, you can walk, you can engage in activities of normal daily living otherwise. There is no physical therapy mandate. Physical therapy is not a component of this to make it work better. What makes it work are the particles that go in that cut down on that circulation. Physical therapy does not have a role in the recovery from this procedure. So, what are the effects of knee embolization for most patients? Most patients have decreased pain, improved functional status, decreased need for medications and joint injections, and overall 70 to 85% of patients who undergo genicular artery embolization experience a clinical benefit from the procedure. A majority of the patients, a large majority. So, talking about decreased pain, improvement is rapid. In patients who are responders, the 70 to 85%, they report a 54% decrease 1 week after the procedure. And this is something we definitely see in our own practice. These patients have an improvement rapidly after the procedure. And it's a sustained downward trend. It's one of the interesting things about embolization is you not only have that initial response, where your pain improves, but your pain continues to improve over time. And we find that your pain is better at 6 months than it was at a week, and your pain is better at 2 years than it was at 6 months. And at 2 years, patients report an 84% improvement in pain in whichever knee has been treated. Improve functional status. That sheet that I showed you with all the questions, that was the WOMAC sheet. And as the numbers go down, that means that you have an improvement in your functional status. And what we find in our patients and what we find in the literature is that at 6 months, patients report a 73% improvement in all of those different questions. That it does include pain, but it also overwhelmingly includes functional status. We find that functional status improves 79% at 12 months and 85% at 24 months. So patients who respond, the overwhelming majority, experience approximately 85% reduction in pain and 85% improvement in function at 2 years after the procedure. One question I'm often asked is, does embolization damage knee structures, things that were otherwise normal? Does it hurt them? And we can say absolutely not. That we have high resolution studies published in the literature that show that adjacent structures, things that were normal to begin with, do not become abnormal after you have knee embolization. It affects the circulation only and improves symptoms. So, which patients may benefit from genicular artery embolization? Chronic knee pain sufferers, individuals with mild to moderate osteoarthritis, who have not found relief with medications, who have not found relief with physical therapy or joint injections, or have found that they've had diminishing returns over time and are looking for something different and something that may offer them longer term improvement in their symptoms and functional status. Also, individuals with severe osteoarthritis who are not candidates for knee replacement or simply wish to avoid or delay replacement surgery. And this oftentimes applies to younger individuals, but not exclusively. And we have a number of patients who have had prior surgery and have found that it did not improve their symptoms, and they go on to get a knee embolization, including patients who have had a complete knee replacement, because a significant percentage of those patients can continue to have knee pain even after they have joint replacement. Patients who are not ideal candidates for surgery for whatever reason, medical comorbidities, advanced age, or personal preference to avoid surgery. And finally, individuals looking for a minimally invasive treatment that does not require anesthesia, does not require hospital stay, and does not require prolonged recovery, including physical therapy. Patients who are looking to get on with their lives as quickly as possible after the procedure. Those are patients for whom this is an attractive option. And in summary, knee embolization is a minimally invasive treatment option for patients with knee osteoarthritis with pain and disability that offers long-term improvement in pain and function in the overwhelming majority of patients who undergo the procedure. Thank you.